So let's then take the discussion to the next line of therapy, which is second line treatment. Let's assume that the patient we're talking about or we have in mind has not seen a checkpoint inhibitor in the first line and has seen platinum-based chemotherapy. Then for salvage therapy, we have 3 immune checkpoint inhibitors that are approved: pembrolizumab, nivolumab, and atezolizumab, 2 PD-1 inhibitors and 1 PD-L1 antibody. Benjamin, walk us through some of the key data in the second line space with salvage therapy, and how should physicians go about making decisions for their patients?
So nivolumab and atezolizumab were tested against chemotherapy in all comers, whereas for pembrolizumab, it's restricted to PD-L1 positive tumors with a threshold of 1%. So roughly a third of the patients will be PD-L1 negative and will not be treated by pembrolizumab. All these studies are positive and show that in all comers, or PD-L1 positive for pembrolizumab, the immunotherapy performed better than chemotherapy. This was the first study done with immunotherapy, but the field is moving fast. And now we have immunotherapy frontline, meaning that we will treat a second-line population that is different, because a third of the patients will receive immunotherapy frontline. And now in second line, we will enrich in PD-L1 weak or PD-L1 negative NSCLC patients. And we don't have data on these specific population. We have subgroup analysis from the phase 3 study that show that there is clearly a link between the activity of the immunotherapy and the positivity of PD-L1. Now, in the PD-L1 negative, which is a third of the patients, or roughly the study says it's equal. It's maybe a bit better, maybe a bit worse, but it's equal. So a lot of people say, well, let's give immunotherapy to anybody in second line because it's less toxic than chemotherapy, and it's true, it's less toxic, and it's the same efficacy. And I completely disagree with that. We have PD-L1 testing, but if it's not available or not done or not enough tissue, there are other factors that you can rely on. Smoking status is really something that is predictive of the efficacy, and in never smoker, we should probably avoid to give second-line immunotherapy. In EGFR mutated patients, it's also proven, and 10% of our patients, that immunotherapy is probably not the best option. We know that in a subset of patients, maybe 15% of the patient, immunotherapy may hurt because there are new data that show that the progression of the disease may be increased by immunotherapy in some cases. We don't know why, but it might explain why the survival curves cross when you compare immunotherapy to chemotherapy. So I think second-line immunotherapy must not be reflex second-line, like you receive chemo, you will receive immunotherapy. We still have to select the patient for second-line.
Thank you. That was very helpful to make choices in the second line. Can I also ask the panel about the role of chemotherapy? Docetaxel, ramucirumab is an approved salvage therapy regimen. Where do you see that antiangiogenic chemotherapy combination play in non-small cell lung cancer? Giorgio?
Well, as Benjamin just said, there is a subgroup of patients in which immunotherapy is not probably the right choice. Okay, we have different therapeutic options, and in the United States and in Europe, we have the ramucirumab and docetaxel combination. In Europe, we have an additional indication in second line related to another VEGF TKI that is nintedanib in combination with docetaxel. There are therapeutic options. There are therapeutic options that are coming with some toxicities, and this is something that we need to factor in our treatment strategy. It is true that we are dealing with some toxicity with immunotherapy that are definitively less than with standard chemotherapy. But also in the combination of an antiangiogenic agent and docetaxel, we are dealing with a significant amount of mainly hematological, but also non-hematological toxicities. And again, I believe that one of the major challenges that we have in our clinical practice is to profile in the best way our patients, to match each individual patient with multiple therapeutic strategies that we have.
But Giorgio, maybe well, in these second-line antiangiogenic studies, one thing was quite impressive. It's the activity of the combo in the refractory patients, the one that progress in the, let's say, 3 months after the end of the platinum-based chemotherapy. And my preferred treatment in these refractory patients is this kind of chemo antiangiogenic combo, at least when there is no high PD-L1 expression.
Yeah, when I was alluding to the patient's profile, I was exactly alluding to what you are referring on.
And I think that also performance status must be considered for the choice of the second line, which is maybe the most important factor.
So we have immunotherapy as one line, we have platinum doublet as another line, and potentially for patients who still have a good performance status, then docetaxel, ramucirumab combination could be another line of therapy. So clearly we now have effective options. It boils down to selecting patients based on molecular status for targeted therapy for EGFR, ALK, ROS1, BRAF, which we'll talk about in a few minutes, and PD-L1 expression, which helps us decide which patient gets first-line immunotherapy versus first-line platinum doublet. So very exciting observations and developments in that space.